Hi there, it's Rita at Gold Medical Jobs, and today's Friday, and I just wanted to check in real quick. Oh, I didn't give you a title today. Can I add it now? I'll just tell you, I was just thinking about basic assessments because that's kind of nursing 101. It's something we do all the time with our patients. I'm trying to get the glare. There. If I sit up straight, maybe less glare. It's done all the time, and I've been assessing myself because I've been a little under the weather and got my voice back. Excuse me, but I'm still coughing quite a bit. Hang on there. Ooh, that's nice. I'm so sick of drinking so much water that I'm adding, I was going to say apples and oranges. I added lemon and mint today. We do it all the time, but we assess our patients. I think we are very observant people. I don't know if I was that way before as a nurse, but maybe a little, and very much so all the time. My husband's like, you notice everything, you smell everything. Like, I have a funny story with one of my brothers. We were all out, and we were actually at Radio City Music Hall. We were having a family reunion at his place at the time. We called it Royannasport in upstate New York. And so we'd gone to New York City and had lots of cousins and nieces and nephews and brothers and sisters and my mom. And we went to see Radio City Music Hall. My brother actually knew one of the dancers. And during intermission, I'd been looking around and smelling around in the dark theater, but when the lights went on, I realized there were a lot of coats and sweaters in front of us because it was Christmas week, and I smelled Pseudomonas. So before everybody got up and left the theater, I said, look, guys, go wash your hands and don't touch anything around here. You know, this was quite a few years ago before we had hand sanitizers available in our pockets and purses and in facilities. So it meant a trip to the bathroom to wash and to be super careful and vigilant about not touching anything. And my brother said, why? And I said, because I smell Pseudomonas, and it's very contagious. And somebody probably had a wound or something that they were or were not aware of, and maybe got on their clothing, and yuck. So for years, my brother would say, what is it? You smell Pseudomonas? But you know what? Nurses in practice have these little, what are they? Pearls, experiences that they just kind of store. And it just comes from, you know, being in practice. And so there are things that I recognize immediately by smell, immediately by look. I mean, yellow sclera. I'm not saying I have yellow sclera, thank goodness, but you know, they jump out at you. You're very much aware of them, and and it kind of reflects back to things that I spoke to you about recently, which is sharing with your leadership, sharing with your team, getting a second opinion. It's wise, okay? It's not a reflection of ignorance. It's not a reflection of strength. It's wise. And so, for example, you know, you may not be able to pinpoint it. You have somebody sick. They've got a disease process going on. Maybe they've got C. diff. Maybe they've got colitis. Maybe they've got a respiratory situation, a pneumonia, or maybe a bronchitis, and now you think it's advancing. So you just can't put you can't nail it every time. You're busy, you have a lot on your mind. So you say, you know, to your teammate or to the RN working in the room next to you, would you mind coming in? My patient has A, B, and C. Their vitals have not really changed, but they're requiring, say, more oxygen to maintain a 92% saturation. Or, you know, I have orders to adjust it to maintain a 94, and I'm not able to get my 94. And maybe you just didn't notice, maybe you didn't do an orthostatic blood pressure, or maybe you didn't assess all the lobes of the lungs, or you know what I mean? So little things mean a lot, and assessment becomes better and better. And even after I have so many years of experience, I actually started in the late 70s and was clinical many, many, many years. And then, you know, leadership got thrown in there and so forth. So my kind of 40-ish years, I've learned a lot. And I've learned a lot just being clinical myself. And I've learned a lot from others that I work with, you know. And so I thought, let's throw in, when I talk to you, I'll throw in one or two, is it A or is it B? And maybe that's something you can carry around in your pocket, you know, virtually, no, not really carried around in your pocket, but so let's do this. Let's do a respiratory. So when we say head to toe assessment, we mean head to toe. When we're looking at our patients, we start with the head. You know, how do they look? How's their color? How's their speech? How's their mentation? Has it changed? So you really start top to bottom. Then you're going to hit the lungs, the skeletal system. You're going to hit the cardiac, the abdomen, the GI system. You know, and you'll focus on some things a little more than others, depending on what your patient's been admitted with. If it's a patient with an abdominal issue, a colitis, or, you know, there's different labs that you're going to look at. There's, you know, you're going to be more interested in their stools. I mean, you're interested in that anyway, because they're all bodily functions, and you want your patient to be well holistically, but you're going to focus on different things, right? So, head to toe, and you will get down to the toes. You'll be checking fetal pulses and edema and so forth. And you get kind of quick at it and focused at it. And particularly if you're fortunate enough to have worked with this patient the day before or the night before, or whatever, it's helpful and more obvious to see if things are improving or things are changing. So let me, so I wrote down a couple little tidbits. And let's do, is it A or is it B? And it's about lungs. So say you're assessing somebody's lungs and you get to the mid and lower lobes. Now, is it the right? I think the right side has an upper, a mid, and a lower, and the left side has an upper and a lower. So when you listen to your patient, often you're listening high for the lung sounds, and you have them be very quiet and oftentimes inhale and exhale through their mouth. Because a lot of times on that exhale, they're going to wheeze or cough, and that can be significant. Excuse me. You don't really want them making sounds, you know, like hoo hoo, aha. No, just breathing, but opening your mouth. So, okay. So you're assessing the lungs. You get to the mid and lower lobes, and you notice some fine rails, some fine crackles. It's almost like, oh, really faint, like somebody crunching hard plastic paper, or just a little crunching, crackling sound, okay? And you notice that, and you note that, okay? And then you go on, that's one assessment. And how significant is that? And then the second assessment, so that was A. You're assessing lungs, you notice some fine crackles in the mid and lower lobes. Then B, you're assessing lungs and you notice coarse crackles in the mid and lower lobes, okay? So think about that. We'll come back and I'll give you the answer of which is the more significant and which is the bigger red flag. Certainly, if none of those things existed, you're going to report that off. You're going to make a note, and depending on the rest of your assessment, you may or may not call the physician, okay? But I'm looking for what is the most, either the fine crackles or the coarse crackles, which assessment is a red flag for you, okay? So that's in the, respiratory assessment. Let's do a cardiac assessment. Say you have orders to check your patient's orthostatic blood pressure. So that means you're going to check a blood pressure while they're lying, and then you're going to have them sit up, or stand up. Usually sit up is fine. And you're going to check their blood pressure again, or their vital signs. You're going to check their heart rate and their blood pressure. And so now, which is more significant when checking orthostatic blood pressures? Is an increase of greater than 10 in the heart rate with or without a decrease in systolic blood pressure of 10 more significant, or is, when taking orthostatic blood pressures, is an increase of 20 in the heart rate and a decrease of 20 or more in the systolic blood pressure more significant. So we're looking at a patient, we're assessing their cardiac status, and one of the things we do is orthostatic blood pressure. So is A, an increase in heart rate of 10 or more, with or without a increase or decrease rather in their systolic blood pressure. So they're lying down and the systolic blood pressure is 140, and then they sit up and their orthostatic blood pressure is 130. Is that significant? Is that a red flag? Or they're lying down and their heart rate is 80, and they get up and it increases to 100, and their systolic blood pressure decreases from 120 to 100. So let's think about those two, and we'll come back to it. But I did want to talk about assessments being a tool that is constantly in use and that everybody has pretty good awareness of. I mean, it's just kind of nursing 101, but with practice, it will improve. With practice, things will become more and more evident to you. We're kind of almost always on duty. I'll give you a little scenario that happened to me years ago. I'd been practicing for a long time because I think I had 2 children at that time. So by 82, I had 2 children. So let's say this was back in the 80s, and I was working 3 to 11 shifts, and maybe 4 to 12, 3 to 11, I believe. And we were rounding with reports. So I was picking up patients from this nurse that had worked the day shift, and we were going to the bedside. And we're at the bedside, and she was saying, this is Mr. Jones, and he's here for pneumonia or COPD or something. And we're looking up at his lines, and he's getting such and such potassium, and he's getting this antibiotic. And she was explaining how she had set the, we were using a little BARD device. I don't know if they're still in use. But she was showing me how she had set it to infuse over 30 minutes, something. But as she was doing that, you kind of get that wide scope, like when you're driving in a car, you're looking ahead of you, but you're getting also what's going on both sides, and you're glancing in your side views and your rear view, so you're kind of doing the big picture. As she's talking about the meds and the drips and the patient, I'm looking at the patient whose head was only up about 15 degrees, and he's struggling to breathe. He was a long drink of water. I want to say he was probably in his 70s at least, maybe a little older. And I said to her, just a minute, are you all right? And he couldn't respond. He was struggling to breathe. So I immediately cranked up the bed to see if he'd get any better. I glanced at the wall to see what his oxygen is at. And I say again, Mr. Jones, are you all right? He still couldn't respond, and I hit the red button. I called the code because he was not doing well and he was not improving, and I didn't know enough about him. He didn't arrest. No, we got a respiratory treatment in, and that nurse just disappeared. Anyway, no fault to her necessarily. She kind of in her head was already off duty. She did her job in giving me a report, but assessment is always going on. So today I wanted to talk about assessment. Let's go back. I'm kind of rushing because I I have so much other work today to do, as so many nurses are too busy. Take a breath. It'll all get done. Or if it doesn't, it's not all that important. So we were talking about, I was giving you two kind of Q&As here, and I will give you the answer. My first question was, in your assessment of a patient's lungs, which is the more critical, which is the red flag for you when you're assessing lungs? And I said, is it when you get to the mid and lower lobes of the lungs and you notice fine crackles, little, it's like, I can't explain it to you. You could go ahead probably and Google it or talk to your instructor, or I don't know if you're a newer nurse or an older nurse, but you can listen to sounds. You can audio listen to sounds. I didn't have that back in the day in the 70s when I started, but I would recognize fine crackles, and I'm pretty sure you would too. So what's more significant in the mid and lower lobes? Is it the fine crackles or is it the coarse crackles? A or B? It's B, because coarse crackles are defining more fluid in the lower lungs. It's a red flag because you can't have fluid in your lungs. I mean, I probably have a little. If somebody listened to me, I know when I take a deep breath and exhale, I'm still coughing because my lungs suffered, with asthma and infection that I went through, that I'm going through. But I don't have coarse crackles, thank God. If I did, it's definitely a red flag. You need to get the doc involved and see what you can do about that. Okay, my second assessment Q&A for you today was when you're checking cardiac on your patient. You're checking vital signs, you're listening to heart sounds, and you may or may not, usually do this with an order, is check, or if you've had the patient before and you're concerned about it, nobody says you can't do this assessment. You do an orthostatic blood pressure check. And what that is you check them, your patient lying down, get your vital signs, get your heart rate, your respiratory, your blood pressure, and then you sit them up, high Fowlers, feet on the floor is great, and check it again. So what would be more significant? What would be the red flag for you? Would it be A, if their heart rate increased by 10, and or if their systolic blood pressure decreased by 10? Or B, if their heart rate increased by 20 and their systolic blood pressure, their heart rate increased and their systolic blood pressure decreased by 20. And when I'm saying 20, I guess I should make it more mathematical. Hang on, I'll give you. It's 10 millimeters anyway. Shoot. Yeah, I've been 10. Oh, well, you know what I mean. 10 points, okay? So, yeah, it's, I'm not going to get high science on you. So, A, increased heart rate, 10 by 10. So it goes from 90 to 100 or 100 to 110. And systolic may or may not change, but if it changes by 10 degrees, it went from 110 to 100. Is that your red flag? Or an increased heart rate of 100 to 120 and a decreased systolic blood pressure of 120, say, to 100. Ding, ding, ding. It's the second one. It's the 20 milligrams, and that is a red flag. And your patient is showing some significant cardiac changes. So, so there you go. Little things mean a lot. Assessment is always going to happen. For me, it's like ongoing forever and ever. As a matter of fact, when I'm with my nurse friends, I'll go, something's wrong over there. Something's wrong over there. Or I'm at a theater with my family and I'm like, don't touch, there's Pseudomonas, or you smell blood, or you just, sorry, it happens. I'm sure it happens to docs too. And lots of healthcare people become hyper aware. And thank God for that. It saves lives. It's happened to me in all different situations, at work and off, in the office, in the clinical setting. And I'm kind of grateful for it. I'm not sure everybody around me is grateful for it. But yeah, my life as a nurse Good stuff. All right, so Friday the 15th, I believe, yeah, and of November, and I wish you well. Happy times at work doing your assessment. You guys are great. Gold Medical is here for all those healthcare workers interested in different venues, different employers. Gold Medical is created just for you. Okay, easy peasy, no cost to any healthcare worker that wants to sign up and get their resume in there, as little or as much information as you want to put. And Gold Medical is there for employees in all facets of healthcare and wellness, in clinics and hospitals, in skilled facilities and home health. We're here for you so you can meet your next best employee. And I kind of repeat myself a lot, but I don't know if you're tuning in for the first time. I'm Rita. I'm an RN for like 100 years. No, started in the 70s. Love, love, love being an RN. And you can find us on Instagram, Facebook, Twitter. Yeah. And we're hoping to become more interactive so that you can send in your questions. But in the meantime, please use the email, either Paul is Dr. Gold at Gold Medical, and Paul at goldmedicaljobs.com, or Rita at goldmedicaljobs.com. And anything you're interested in, we can talk about, or I can refer you. If you have questions about Gold Medical, we can share information with you. And okay, blah, blah, blah. Thanks a lot for listening. Have a beautiful weekend, on duty or not. Take care of yourself, take care of your patients, and be well. Bye.